The first inherited immune deficiency disorder that we'll deal with is the X-linked agammaglobulinemia of Bruton. As the name implies, this is an inherited immunodeficiency that tends to preferentially affect boys, not surprisingly given the name of an X-linked deficiency. It is characterized by the developmental failure to produce mature B cells and plasma cells, resulting in the agammaglobulinemia. Genetics have demonstrated that the mutation here is in B-cell Bruton tyrosine kinase, responsible for phosphorylating various proteins within the cell. Again, as the X-linked part of the name implies, this is a disease that affects male infants. They are characterized by having recurrent bacterial infections beginning around age 6 months as the protection from mother's antibodies begins to wane. The sort of infections that one will see in these children are things such as recurrent bouts of pharyngitis or otitis media that develop into bronchitis and pneumonia. The organisms are a variety ranging from H. flu to pneumococcus to Staph aureus. Now, cell-mediated immunity, however, is unaffected in these patients, and so the finding here that may help differentiate this disorder from other things such as SCIDs is that these children do not show increased infection due to the fact that their cell-mediated immunity is intact to various viral and fungal infections, in contrast, for example, to children who are affected by things such as severe combined immunodeficiency. Histologically, what your pathologist will report is the absence of plasma cells, and when they're looking at lymphoid tissue, absent or poorly defined germinal centers. The common variable in immunodeficiency is another form of inherited immunodeficiency, which is characterized by a B-cell maturation defect and hypogammaglobulinemia. Clinical findings here will be similar to what one might see in Bruton's. You'll have the onset in childhood with recurrent bacterial infections, in addition to increased susceptibility to organisms such as Giardia lamblia. Similar to what one sees with Bruton's disease, there's an increased frequency of developing autoimmune disease, and for some reason that is not quite clear to us, the increased risk of developing lymphoma and gastric cancer, despite the fact that one's underlying condition is a defect in the development of one's immune system. DeGeorge syndrome is a particular form of congenital immunodeficiency that is associated with various characteristic facial features, a risk of cleft lip and palate, and changes within the thymus. It results from an embryologic failure to develop the third and fourth pharyngeal pouches, which leads to an absence of both the parathyroid glands and the thymus. One also sees abnormalities in the mandible, ear, and aortic arch, the former of which may lead to some of the characteristic facial dysmorphology that characterizes DeGeorge syndrome. Clinically, what one also sees in these patients is, not surprisingly, with the absence of the parathyroids, hypocalcemia and abnormalities in calcium level regulation, tetany resulting from the abnormalities in calcium regulation, T-cell deficiency, recurrent infections with viral and fungal organisms. And the way for you to remember this for the exam and for when you're on the wards is with the mnemonic catch-22, where the C stands for the cardiac defects that affects these patients, A for their abnormal facies, again perhaps due to the abnormalities of the mandible and ear, the thymic hypoplasia, which leads to the T-cell deficiency, cleft palate, hypocalcemia, and the microdeletion on chromosome 22, which removes the genes responsible for this disorder. Now, severe combined immunodeficiency is a generic term that covers two particular forms of inheritance that lead to essentially the same clinical presentation. There is an X-linked form of this disorder, which naturally enough is going to affect male children, and an autosomal recessive form that can affect both males and females. The breakdown in terms of the percentages from each form of inheritance is approximately 50-50. The definition of this disorder is, as the name implies, a combined deficiency of cell-mediated and humoral immunity, often caused by a defect in the stem cell that is supposed to lead to the development of both B and T cells. Hence, in general, both will be low in these patients, although there is a slight difference between the two forms of inheritance. Those patients who present with the autosomal recessive form of severe combined immunodeficiency due to a deficiency in adenosine deaminase, these patients will tend to have deficiencies both in B and T cells. Those patients with the X-linked form who have a mutation in the chemokine receptor will tend to see T cells affected preferentially, with a slightly lesser effect on T cells. As the name severe combined immunodeficiency implies, these patients are at risk for a variety of infections. Here, in contrast to things such as Bruton's, they have recurrent infections not just with bacterial organisms, but with fungal, viral organisms, and protozoa. You will see them having susceptibility to organisms such as Candida, CMV, and pneumocystis, much as what one might expect to see within a patient affected by AIDS. They have adverse reactions to live virus immunizations, hence why one must be very careful in how one goes about giving these patients their typical childhood immunizations. And similar to Bruton's and other immunodeficiency syndromes, they are at increased risk for various malignancies. They are also at risk for graft-versus-host disease as a result for blood transfusions or bone marrow transplant, which is the only way we have currently of treating these patients, although this has been one area where there has been some early success in trying to treat these patients with restorative gene therapy. Unfortunately, most infants die due to the large number of infections within a year if they're not treated with something such as bone marrow transplant. Wiskott-Elder syndrome is an X-linked recessive immunodeficiency syndrome that's characterized by some unique skin findings that may help you clinically differentiate it from things such as severe combined immunodeficiency and Bruton's. It is an X-linked recessive disorder with mutation for a gene, for the WASP gene. The triad that the patients present with clinically here is similar to what one might see with SCIDs or Bruton's, recurrent infections, a severe thrombocytopenia, and then a often very severe form of eczema. These patients respond very poorly to polysaccharide challenges that might come from different infectious organisms, but have normal IgG levels. The treatment here is similar to what one might do for SCIDs. You would treat the patients with a bone marrow transplant, and like patients with other immunodeficiencies, they are at increased risk for lymphomas and often die due to infection or hemorrhage. Now, there are various other immune deficiency syndromes that are not primary in nature, but result from some other underlying condition from which the patient suffers. Various systemic disorders can lead to a patient being immunocompromised. Perhaps the most common of these is diabetes. The various collagen vascular diseases, however, can also put the patient at risk for an immune deficiency, particularly if the patient needs to be treated with high doses of corticosteroids. And finally, chronic alcoholics, for some reason that's not entirely clear to us, are also at increased risk for developing immune deficiencies. Now, patients who undergo transplants of various organs, whether that be heart, lung, or kidney, are also at risk for developing immune disorders and immune deficiencies. These can result either from things that we do to them, such as making them purposefully immune deficient so that they don't reject their organ, or can be due to the fact that complications that arise from the rejection of the transplanted organ itself. The model for rejection of the transplanted organ is that occurs in renal transplantation, and the model that is often followed when one is trying to look at rejection of other organs, such as the heart, lung, or liver. Remember that following renal transplantation, patients are immunocompromised due to the immunosuppressive drugs that are brought on board to try and keep them from rejecting their new kidney. Hence, you always have to be worried off the top of the bat with these patients that they're going to develop infections that result from their immunocompromised state. Hence, these patients must be considered to be at increased risk for the various opportunistic infections and fungal infections such as Candida, Cryptococcus. One must think about pneumocystis within the lung, and think about the various opportunistic viral infections such as CMV. Now, in terms of analyzing the kidneys for rejection, there are various stages through which the rejection can occur. Rejection that occurs, as it were, on the table itself during the actual transplant, after all the anastomoses have been made, is termed hyperacute rejection. This is mediated by preformed antibodies that attack the new organ itself and occurs immediately after transplantation. Indeed, the surgeon and nurses present can watch the organ itself being rejected by the body before closing up the patient. Microscopically, what one sees when the organ is removed and one analyzes it under the microscope is a neutrophilic vasculitis with severe thrombosis. Now, if the patient makes it past hyperacute rejection, the next phase that one worries about is, not surprisingly, acute rejection. In terms of a timeline, this is a rejection that occurs weeks to months after the initial organ transplantation. What will occur clinically is that the patient may be going along fine, there may be a slight change in their immunosuppressive drugs, and all of a sudden the patient will have the abrupt onset of oliguria, the production of very small or no urine at all, and azotemia, increased amounts of protein within the blood. The picture here histologically is similar to what one might see within hyperacute rejection. You will see a neutrophilic vasculitis, but here lymphocytes will begin to play a role as well, as you will see them begin to infiltrate the surrounding interstitium. Finally, if one follows the patient's timeline, they can develop over months to years a chronic rejection pattern. Here what happens is that rather than having the acute onset of oliguria and azotemia, instead when the patient is being monitored in the clinic, there will simply be the gradual onset over time of oliguria, hypertension, and azotemia. When the organ is removed and examined, what you will see is an intimal fibrosis of vessels and a preponderance of interstitial lymphocytes and a very poor response to efforts to increase immunosuppression. This now brings us to perhaps the largest and most researched topic in the area of immunodeficiency syndrome, acquired immunodeficiency syndrome, or AIDS. AIDS is defined as an HIV-positive individual who has a CD4 count less than 200, or a person who is HIV positive and has an AIDS-defining illness. We'll define in a few moments what some of those AIDS-defining illnesses are. The transmission of HIV should be well known to most of you from the various professional and public literature that has been made available over the last 20 years. However, we will review it briefly. HIV can be transmitted through sexual practice or parenterally through IV drug abuse. Hemophiliacs were exposed to this disorder when we were unable to screen our blood supplies in the U.S. and in other countries. Blood transfusions are one way of being at risk at this, although this risk has decreased quite dramatically over the last several years as our screening processes for HIV have become more and more precise. And finally, needle stick exposures that may occur, for example, in health care professionals, are a very minor route of being exposed to HIV. Very briefly, just to review what HIV is, it is an RNA retrovirus that encodes a reverse transcriptase. The HIV itself likes to infect CD4 positive cells. This includes things such as T cells, macrophages, monocytes, and then cells that one might not expect to be CD4 positive, such as the dendritic cells and the microglia of the brain. How this occurs is by the binding of the CD4 receptor by the GP120 protein that's present on the virus itself. The virus enters into the cell by fusion between GP41 and various co-receptors that are present upon a CD4 positive cell. The receptors are things such as CCR5 and CXCR4. Some of the more interesting findings in the research in HIV over the last several years has been the finding of mutations in CCR5 and CXCR4 that render some populations of individuals more resistant to infection with HIV because it cannot bind appropriately to these receptors due to the mutations that are present. If you're testing a patient for HIV, it can be found in various body fluids, including blood, semen, vaginal secretions, breast milk, and saliva. High-risk populations are considered to be homosexual and bisexual men, making up about 75% of new cases of HIV, intravenous drug abusers, which make up about 15% of the remaining cases, and then the remaining 10% being heterosexual partners of high-risk individuals, patients who for some reason have had to undergo multiple blood transfusions, and infants of high-risk patients. Pathogenesis of how AIDS develops from infection with HIV. HIV, not surprisingly, depletes CD4 positive T cells, leading eventually to an imbalance in the CD4-CD8 ratio. Indeed, this will be one of the measures that you will use, those of you who treat HIV-positive populations, to measure the extent of their disease. This loss of helper cells causes failure in both humoral and cell-mediated hypersensitivity reactions and an inability for the body to produce specific antibodies. Interestingly, there is a paradoxic hypergammaglobulinemia that occurs from polyclonal B cell activation. You diagnose HIV by taking an appropriate blood sample from the patient and looking for the antibody via ELISA testing, and then doing a confirmatory Western blot. To monitor patients who are infected with HIV, as we indicated earlier, you do a CD4 count and monitor the status of the number of CD4 cells present in the body, trying to see that the patient, again, does not drop below 200. Today, with the advent of various molecular genetic techniques, we can also monitor the patient's HIV load, and by measuring the amount of RNA present by techniques such as the polymerase chain reaction. The goal, indeed, of many of our therapies for HIV, which include various antiretroviral treatments, the use of reverse transcriptase inhibitors, protease inhibitors, and prophylactic treatment of various opportunistic infections, is to try and keep the patient's HIV RNA load to negligible levels. Now, the acute phase of HIV can be mistaken for various other disorders. Indeed, HIV itself, particularly in the acute phase, can take on the role of the great mimicker occupied by syphilis in the history of man. The acute phase is often that of an acute infection that can mimic something such as mononucleosis. There's initial viremia with a reduction in the CD4 count, with, again, a mononucleus type picture of viral symptoms and adenopathy, and then the patient eventually seroconverts. The latent phase, the patient can be asymptomatic, feeling well, or perhaps just with a generalized lymphadenopathy that is not noticed unless the patient actually undergoes a physical exam in the doctor's office. There continues to be viral replication in reservoir sites, including the tonsils, but there will be low levels of virus within the blood. At this point, the patient may begin to develop various minor opportunistic infections that may indicate that there is some sort of defect present within their immune system. Hence, you may see a patient who, for some reason, has suddenly developed thrush, the presence of oral candidiasis, or perhaps has a reactivation of herpes zoster. The average duration of this latent phase can be up to a decade. The progression to AIDS is due to the increased reduction of the CD4 count, again with the definition of AIDS being one of them being a patient who's HIV positive and has a CD4 count that dips below 200. Viremia reemerges, and the patient begins to develop some of the AIDS-defining illnesses. And if not appropriately treated with the appropriate antiretroviral therapies and protease inhibitors, will eventually die from one of these, most likely from one of these opportunistic infections. Now, the opportunistic infections that define AIDS are very wide, and essentially one should consider anything that can infect a human being when they're immunodeficient should be considered a possible etiology in a patient with AIDS, particularly one who is not adherent to their treatment protocol. Thus, one should think about not just the standard bacterial infections, but unusual pathogens such as pneumocystis. The reemergence of tuberculosis has been due in part to the development of HIV-positive populations and the presence of different forms of mycobacterium, such as Mycobacterium avium intracellulare. Your fungal infections will also play a greater role within this population, coccidiomycosis or histoplasmosis, depending on what part of the country you happen to be in. Cryptococcus is also a major player, particularly in terms of CNS infections in this particular population. And of course, we've already mentioned candidiasis of the mouth and elsewhere within the body, such as the GI tract. Also think about opportunistic viral infections, the presence of cytomegalovirus with its particular pattern of both nuclear and cytoplasmic inclusions, or the reactivation of herpes zoster infections. Herpes itself just presenting histologically with nuclear inclusions. Clinically, what you might see is the reactivation of herpes either in the gingiva or around the mouth, or perhaps the presence of shingles in patients who have not been affected with that disease before. Also think about the presence of aspergillus in the lung or in the brain, toxoplasmosis in the brain, and then the presence of other particular opportunistic infections such as JC virus, which we will talk more about in the CNS section of the pathology series, which leads to the particular form of leukoencephalopathy, progressive multifocal leukoencephalopathy, with the specific infection of the oligodendrocytes of the brain, and then things such as hairy leukoplakia, which we will deal with in the oral pathology section of this review. Other complications of HIV infection can be things such as Kaposi's sarcoma, a particular form of sarcoma associated with the infection with the human herpes virus 8. You will see Kaposi's within the skin, the GI tract, lymph nodes, and limbs. Patients with HIV are at increased risk for various non-Hodgkin's lymphoma, cervical cancer, and then can also develop various disorders that we do not have a particular good explanation for, but are associated with infection with HIV. This includes a particular form of wasting disease, simply known as the HIV wasting syndrome, and then a particular form of HIV dementia, whose pathogenesis is at this time still unclear to us. These patients can also develop infections in their kidneys with a particular form of AIDS nephropathy developing.